All right, good morning, everybody. It's 10 o'clock on the dot. I'm very excited to be moderating today's session at the Norman Education Research Day entitled Education Research in the Time of COVID. My name is David Zorko. We have 5 really exciting presentations today in this session. A few announcements before we start. First is to make sure that your video and audio is off during the presentation, unless of course you are the presenter, then you are welcome to turn your video and please your audio on. These sessions are being recorded and this will be posted on YouTube for public viewing. And if you have a question during the session, you can ask your question in one of 2 ways. At the end of the presentation, you can raise your hand and I'll call upon you to ask your question, or you can type it in the chat and then I can read it out for you. Each of our presenters has 10 minutes today in total for the presentation and question and answer period. If you're still presenting at the 1 minute mark, I will let you know. So without further ado, we will go to our first presentation today, which is Anita Akai, who will speak to us about an iterative approach to promoting departmental well-being during COVID-19. Anita, the floor is yours. You're muted.
There we go. Thanks very much. Just making sure that it's working. Okay, there we go. Okay, so today I'm presenting this on behalf of my colleagues, Andrea Gonzalez, Karen Saperson, as well as our Department of Psychiatry COVID-19 Wellness Working Group. So it was a collaborative initiative. And the COVID-19 pandemic has really placed an immense strain on healthcare systems around the world. So in addition to faculty, the majority of whom are healthcare providers, clinical departments at academic centers also include members from many professional backgrounds, and that includes learners and staff as well. So more than ever, the onset of the pandemic has reinforced the need for continued and systemic efforts to foster well-being among all clinical academic department members. So in this study, we use the Plan, Do, Study, Act, or PDSA, Quality Improvement Cycle to describe an iterative approach to conducting a needs assessment and implementing a COVID-19 related wellness initiative in a psychiatry department. The overarching goal of our initiative was to maintain an up-to-date pulse on department members' needs as they evolved throughout the pandemic, as well as to inform broader supports within the department. And in sharing this work, what we're hoping is that other departments and institutions can use our experiences as a model to help inform their own needs assessments and support programs in their context. So for context, our Department of Psychiatry at McMaster is a clinical department with about 400 members. And the department is home to clinical and non-clinical learners and faculty, as well as a range of research and support staff. And wellness is a key component of the department's mandate, and it is also in the portfolio of the vice chair of the department. So in the planning phase of the PDSA cycle, the department quickly mobilized to convene a COVID-19 wellness working group at the onset of the pandemic in March of 2020. An open call for members was sent out, which allowed all interested parties in the department to let us know that they were interested and join our working group. Initially, a group of 17 members met virtually on a weekly basis to establish a plan for supporting department members during the pandemic. And we decided early on that particular things that we wanted to work on were the deployment of monthly surveys to gauge departmental needs and the curation of a new resources page on our website that members could go to for additional resources. In the do phase of the cycle, we divided and distributed tasks among members with the available time and expertise. And a core group of members trained in assessment and research methods helped develop the monthly surveys. Another subgroup worked together to curate COVID-19 related resources for the website. And following the first set of survey results, we convened a weekly online drop-in support group. We also formally connected with both hospital and faculty-based wellness support services to ensure the coordination of resources. In the study phase, regular anonymous surveys were emailed to all department members, and these were really critical for understanding members' needs as they evolved during the pandemic. Surveys were sent out approximately once every month for 3 months, And in addition to evaluating members' level of satisfaction with the supports being offered and inviting suggestions for improvement, the surveys also provided a way of monitoring members' current stressors, levels of coping, and mental well-being. And certain questions, such as those related to coping, stressors, and well-being, were kept consistent to allow comparisons of responses over time. And finally, in the ACT phase, the results of each survey were summarized using descriptive statistics and taken back to our working group for discussion. And they were subsequently shared with departmental leadership, who provided a high-level summary at department meetings. And specific action items were developed following each survey, representing an iterative feedback loop. In addition to the PDSA cycle, you'll see that we also use Schoenfeld and colleagues' framework for supporting healthcare workers during the COVID-19 pandemic as a sensitizing concept to help guide the development of our initiative. And this framework was based on evidence from consultations with 69 healthcare workers that Schoenfeld and colleagues engaged in, and recommended the following 5 levels of support: hear me, protect me, prepare me, support me, and care for me. Turning now to our findings, our survey response rates ranged from 22 to 32% throughout the course of the initiative. And a range of stressors were identified that ebbed and flowed throughout the course of the pandemic. Early concerns were mostly related to addressing clinical issues and providing safe patient care during COVID, as well as the need for rapid information sharing. And as safety protocols began to be established, fears around contracting and transmitting the virus became less pronounced, and then were replaced by the effects of a loss of routine and difficulty maintaining productivity. And department members also reported being challenged by a loss of income due to reduced clinical loads, childcare issues, and loneliness. And later, participants reported concerns around return to work protocols and uncertainty about what the future would hold. Across multiple surveys, about 80% of respondents felt supported or very supported by the department, and 90% were satisfied or very satisfied with the quantity and quality of information provided. Nearly a quarter reported attending the support group at least once, and close to a third reported accessing the online resources page. An unintended consequence of our approach to supporting departmental well-being during the pandemic was that our surveys revealed not only concerns related to the pandemic, but also other departmental and societal issues affecting members' well-being. And one example was the Black Lives Matter movement, which had led to a renewed focus on equity, diversity, inclusion. Given their importance, these issues did become part of the mandate of our working group. And finally, I just want to share a few lessons about what contributed to the success of this initiative. So first, the iterative nature of our approach helped us identify how needs shifted over time and helped ensure that the supports we were offering remained relevant. Another factor critical for success was the engagement of stakeholders in the dissemination of findings. Having senior leaders share the survey results and resulting action items at department meetings showed members that their participation was valued and ensured that they continued contributing their perspectives in future surveys. And a third factor was the working group's coordination with other units, which helped streamline the provision of services and ensure the long-term sustainability of the initiative. The working group has now become a more permanent fixture of our department through the development of a terms of reference, and we have also convened a speaker series that will help create opportunities for connectivity and provide participants with additional strategies for maintaining well-being. And there is also the potential for a model to be scaled to create a faculty-wide, institution-wide, or regional approach to addressing well-being. And this could increase the capacity to provide support and help address issues of confidentiality. Finally, our working group does remain very focused on continuing to promote equity, diversity, and inclusion through our membership, operations, and collaboration with other groups. Thanks for listening, and I look forward to your questions.
Thank you, Anita. This is, when I was reviewing this slide, this is really interesting, very topical. I read the other day in the Washington Post that 3 out of 10 healthcare workers in the States are considering leaving their profession after COVID-19. And when I read your study, it just paralleled that article so nicely. We have a question in the chat from Sam, and I'll read it for you. Thank you for your presentation, Anita. Was there any consideration to the phenomenon of the results representing those who responded versus those who did not? For clarity, survey respondents are often similar to one another, and non-respondents are not represented, such that the results do not reflect the needs of the non-respondents, who are the larger portion of stakeholders.
Yeah, this was certainly a consideration, and we had to balance it against the anonymity of the survey because it was on such a sensitive topic. We ultimately decided not to collect any participant identifiers for the broader goal of hoping that people felt more comfortable responding. We did do another survey in our department related to equity, diversity, inclusion, and well-being in December of last year. And there we were able to look at the demographics of respondents versus non-respondents. We found that there were some folks who were located at distributed sites and they were less likely to respond to our survey. And so we wonder if a similar phenomenon might have occurred for these wellness surveys as well.
Anita, I have a question. Did you find that supports or stressors differed amongst groups? You talked about interviewing learners, faculty, staff. Did you look at those groups separately in any way, and were there any differences?
There were some in the qualitative comments, and I think that's where the diversity of our department really came through. So we did see some concerns about teaching, about being a student and having to do lots of online lectures or switching learning opportunities to an online format, be they clinical or non-clinical. So certainly those individual aspects came through in the qualitative results, as well as for staff. I think staff are often overlooked, but their workloads in some cases have really increased due to the pandemic and perhaps changed in terms of the nature of the stressors that exist.
And in the last 10 seconds that we have, do you feel that your results are unique to psychiatry, or do you think that these could be generalizable across other departments? Question from the chat.
I think they're largely generalizable. I mean, there certainly are some specific aspects. For example, the idea of providing virtual mental health care and the challenges that creates. One contextual factor is that a number of folks in our department are trained licensed therapists. And so that was really helpful in being able to provide, for example, the drop-in supports and so on. It wasn't a therapy group, but those facilitation skills were really helpful as a contextual element.
Thanks so much, Anita, for sharing your work today. We'll go to the next presentation, which will be by Ines Al-Guhari, entitled Faculty Wellness Needs Assessment and Impact of COVID-19 in the Pediatrics Department at McMaster University. This is very exciting for me because I'm part of the Pediatrics Department at McMaster University. So Ines, the floor is yours.
Hi, good morning, everybody. It's my pleasure to present today the work for the Mentorship and Wellness Committee in the Pediatrics Department at McMaster University. Likewise, the committee actually was established back in November 2019, so before COVID, and was established to develop mentorship programs for our department and evolved into Mentorship and Wellness Committee. So there is no doubt that burnout is a grave concern for physician well-being and is exacerbated by COVID-19. Despite extensive wellness research over 10 years, no clear strategies yield measurable improvements in wellness. Our objective was to identify determinants of burnout and psychological safety and impact of COVID-19 in our department to inform the design of framework to promote wellness, joy in work, and professional fulfillment for all faculty. We followed best practices for survey development, and we conducted the survey among all faculty in the Department of Pediatrics at McMaster University. 148 faculty were surveyed between October to November 2020. This is about 6 months or so into the COVID-19 pandemic. The survey measured demographics, burnout using abbreviated Maslach burnout inventory, psychological safety using Amy Edmondson scale, and factors impacting and strategies to improve wellness with particular COVID-19 related prompts as well. Frequencies and proportions were analyzed. Differences in proportions were assessed using chi-square. We had so much qualitative data, and those were analyzed using thematic analysis. We had a very reasonable response rate, 55% response rate. And the responses from faculty based on the role was very representative of the demographics in our department. Formed mainly, 2/3 of the faculty are clinician educator. And we have small numbers of clinician non-tenure track part-time, clinician non-tenure track full-time, they represent about 17%, researcher educators about 16%, and clinician researchers about 5%. If you look at the graph that's colored right below that donut, on the x-axis, you see the roles, the different roles of faculty, and on the y-axis, you see the percentage of burnout. You're going to notice that burnout rates were highest in the clinician non-tenure track and the clinician educators, ranging between 45 to 50%. There were none, there is no burnout that was reported actually in our small percentage of clinician non-tenure track part-time. If we look up top on the graph in gray, you can see that on the x-axis, we looked at burnout rates based on years of experience. To our surprise, our burnout rates was highest for mid-career faculty with experience between 6 to 10 years at about 50%, much higher than our department average rate of burnout, which is about 38%, much higher also than the National Canadian Medical Association burnout rates that was reported at 28%. Now, it is surprised because the CMA had reported that when you have more experience, you are less likely to be burned out. The other thing that we assessed was psychological safety. Based on the literature and our experience, psychological safety is the prerequisite actually for engagement of teams and also big part of causing burnout. 36% of our faculty reported low levels of psychological safety and likewise reported high levels of psychological safety. So 2/3 of our faculty then not necessarily feeling safe to share their ideas, concerns, or take risks with innovation. Top factors that impaired wellness were workplace inefficiencies, workload and short staffing, impaired work-life integration, and interestingly, sense of lack of support from leadership. That was highlighted through talking about the communication, transparency, and allowing more autonomy to faculty. Top strategies for improving wellness included developing systems to address systemic issues and seeking input from faculty, fostering a culture of respect and autonomy, improving EMR system. Everybody, I think, wants to improve EMR systems, aligning academic expectations with individual career goals, which speaks to how important the purpose and meaning in work in actually promoting wellness. When we asked about the impact of COVID-19, 83% of faculty reported additional stressors because of COVID-19 pandemic, including childcare, their concerns about mental and physical health for themselves and for families, financial stressors, PPE availabilities, and so forth. We asked them what coping strategies that were helpful for them. And when you look at that, we actually mentioned about 10 different coping strategies or strategies that have been implemented to support staff during COVID. Interestingly, the number one strategy, so 85% of our faculty had rated peer support to be the number one strategy that helped coping during this difficult time. Comes after regular communication and transparency and availability of appropriate PPEs. Coping strategy that were helpful for less than 50% of our faculty were guidelines and teaching about PPE, wellness and development sessions, regular leadership town halls, peer support phone line. Now, those are important. They were important for not the majority of the faculty, but maybe 20 to 30% of the faculty. So in conclusion, this survey was very helpful to highlight the priority for us to move forward, which is to address competing demands and workload as the leading factors for burnout in our department. This is also consistent with the higher burnout rates in mid-career faculty and clinically focused faculty who are faced with day-to-day challenges in their workload and efficiency. An effective wellness framework should address system-level issues and ensure inclusive safety culture through leadership training, stakeholder engagement with an emphasis that stakeholders are not only the leaders, but also the frontline faculty and frontline healthcare workers, and to focus also on team building. I would like to acknowledge all the faculty in the pediatric department who provided support and participation in this survey, to the executive leaders in our department, and also our partners in healthcare and the hospital side for their support moving forward. And I want to acknowledge the Mentorship and Wellness Committee members and my colleague Joyce Obeid for all her work in producing this poster as well. Finally, I would like to share with you our future directions. So right now we are developing the wellness framework. We're going forward with focus groups to engage all our faculty and stakeholders to come up with innovative ideas and innovative framework that's based on communication, collaboration, autonomy, and in the middle of that, supporting the purpose and meaning for everyone. Thank you.
Thank you, Ines. This was great. We have a couple minutes for questions. Maybe I'll start off. It's very interesting that this department is so high in burnout compared to the CMA average. Is this a McMaster thing or a pediatric thing that's seen in other pediatric departments? What do you surmise is the reason for that disparity?
That's an excellent question, David. I think it's really the time rather than sort of a true differential, because the CMA was conducted in 2018. So that's before COVID. When you look at data coming from the states, they conducted a Netscape survey, surveyed about 12,000 physicians. When you look at the pediatrics group, the burnout rates were 45 to 50%. So we're seeing a shift definitely in the burnout rates because of COVID. Having said that, 83% of people had reported that their burnout was pre-existing before COVID. The second thing I would say is the response rate. The response rate on the CMA burnout survey was only 8%. Our response rate is 55%. And I always say it looks always like an underestimation, because those who are really burnt out and not engaged, they may not really respond. So we need to keep that in mind.
Very interesting. I think it'll be interesting if you have plans to repeat this survey in the future. And this is one point measurement to see where we're going. Are we heading in the right direction or the wrong direction?
That's excellent. And that's the plan. We're hoping to conduct the survey on an annual basis because we want to conduct sort of a quality improvement framework to improve wellness and joy in work. And this will be our benchmark in about a year or so, after implementing some strategies, of course.
There's a comment by Stephanie Reed in the chat that you can read, which I just think recapitulates upon your future directions. So I think we'll move on to our next presenter at this time. Next, we have two presenters. We have Roya Akbari and Carissa Haman, which will speak to us about professional identity development in the COVID-19 era. Roya, Carissa, the floor is yours.
Thank you so much. So my name is Roya Akbari.
And I'm Carissa Haman.
And we are two students in the class of 2022 who've been working on a project with our supervisor, Dr. Isla McPherson, who's here as well, exploring professional identity development during COVID-19. So we know that medical students develop a professional identity through a process of socialization, going from their existing personal identities, including like race, religion, etc., towards their professional identity, being a medical student, a resident, and then a physician. The role of socialization is crucial in this progression, as peers, mentors, and clinical experiences lead to self-reflection and a sense of belonging. Studies have shown that professional inclusivity is crucial to the development of a strong professional identity, and students experience this inclusivity when they attend clinical placements and when they're treated as future medical professionals by lecturers, doctors, and patients. So professional identity development is one of the key aims of medical training, as the development of a strong professional identity as a physician contributes to a future practitioner's medical professionalism, their self-reflection, their ability to handle adversity, as well as critical thinking. So at McMaster, the undergraduate medical school curriculum comprises several key components, including clinical skills, problem-based learning tutorials, as well as professional competencies. They also participate in various clinical experiences during pre-clerkship, including clinical skills, as well as horizontal and other pre-clerkship electives. So in response to COVID-19 and associated public health risks, McMaster pulled medical students from all clinical environments in mid-March 2020. And for our class, the class of 2022, all components of the curriculum were moved online, except clinical skills, which was temporarily canceled. In addition, any in-person clinical experiences, such as pre-clerkship electives and shadowing, were canceled. Therefore, the purpose of our study is to explore how the lack of in-person clinical experiences due to physical distancing measures in response to COVID-19 have impacted pre-clerk medical students' perception of their professional identity development and their capacity for career exploration. And we hypothesize that students' professional identity development has been negatively impacted by these changes. Additionally, we propose that there may be adaptations that can be made in the pre-clerkship curriculum to support professional identity development during the pandemic and online learning, such as in the professional competencies curriculum.
So we first aimed to answer this question by developing a pilot survey and a subsequent class-wide survey. Now, for the pilot survey, we included questions on a Likert scale, as well as open-ended questions for elaboration. These questions are based on the previous research, as well as the unique McMaster Medicine C2022 COVID-19 situation. We had a 46% response rate out of WRC C2022 students with an N of 12. Our survey theme design is depicted in figure 1 to the left. We developed the survey by performing a literature search exploring professional identity development in healthcare professional students, as well as disaster response and online learning. The questions were tailored based on prior studies, as well as in comparison to the changes that have occurred due to COVID-19. Now, survey questions were divided into 3 categories: professional identity development, COVID-19 response, and career exploration. Within professional identity development, we further divided questions into 3 subcategories: sense of belonging, competency, and social responsibility, which are key facets of professional identity. This pilot survey was conducted on the Waterloo Regional Campus students in order to identify recurring themes and tailor the questions further before including all 3 campuses. We used the results of the pilot survey to create an adapted survey to focus on the highest yield questions and narrow in on key themes noticed in the pilot survey. We also incorporated more questions related to pro-comp experiences. Initially, our questions focused on the professionalism and self-awareness domain, but as we refined our questions, we were able to focus on multiple domains that are relevant to the themes brought up in our primary results. These domains included effective communication, moral reasoning, and ethical judgment, as well as professionalism and self-awareness. The pilot survey was completed when students were in integration foundation with no in-person learning at all, while the adapted survey was completed when students were in transition to clerkship with some in-person clinical skills resumed, but there were no in-person pre-clerkship electives at that time. The survey was disseminated across all 3 campuses with their final results, including an N of 75 with a 37% response rate of C2022 students across all campuses.
So our results can be, from the final adapted survey, can be boiled down into 3 main points. 1, the COVID-19 pandemic has negatively impacted students' perception of their learning, professional identity, and sense of preparation for clerkship. And 2, we can see in the graph on the upper left that students more strongly agreed that in-person peer interaction in teal positively impacted their professional identity, while less students agreed about online peer interaction seen in pink. Additionally, we see in the graph on the top right that most students agreed that online learning negatively impacted their own view of their competency. Third, we found that most students agreed that they reflected more on the ethics and morals of being a physician. They also felt more pressure from the weight of their social responsibility as a future medical professional and were willing to participate in patient care despite personal risks since COVID. The graph on the bottom right shows that students agreed more that they were worried about contracting an infection as a healthcare professional than before COVID. So taken together, our results show that COVID-19, online learning, and suspension of clinical activities has negatively impacted students' perception of their learning and competency, as well as their sense of professional identity and preparation for clerkship. The pandemic has also increased students' awareness of their social and professional responsibilities as physicians.
Additionally, as mentioned before, in the second survey, we were able to add questions specific to the impact of the ProCop curriculum on student learning during the pandemic. We found that 1, students did not agree or disagree that the ProCop curriculum allowed for adequate preparation for patient support and management in regards to the COVID-19 specific sequelae. And from this, we can extrapolate that adaptations can be made to the pre-clerkship curriculum to reflect the society-wide effects of COVID-19. 2, we found that students also do not agree or disagree that ProCop improved their sense of belonging in the medical professions. And 3, students do not agree or disagree that ProCop helps maintain the connection with the medical profession despite being isolated from peers and colleagues due to COVID-19. A goal of medical education is professional identity development. Now, based on existing literature, professional inclusivity is an important factor in the development. These findings suggest that there may be adaptations of pre-clerkship curriculum to support a belonging and inclusivity in the profession to better facilitate professional identity development in times of online learning and limited clinical experiences. Now, our findings raise many further questions to explore. They suggest that there are adaptations that can be made within our pre-clerkship curriculum and extracurricularly to improve students' professional identity development in medical school, given the pandemic situation and online learning. Our next steps include evaluating such adaptations, such as the effectiveness of simulation sessions and supporting professional identity development virtually. We will now gladly accept any questions. Thank you.
Thank you, Roya and Carissa. This was a very thoughtful question, and I think this idea of professional identity development is so important. I think your study is a bit of a mixed bag. There's some maybe negative findings, but also some positive findings. I was really impressed by this reflection on moral obligations of being a physician. How do you think that those findings can be leveraged post-pandemic to sustain those social rules and responsibilities in medical learners?
Yeah, that's a great question. I think for people who, like the students who have been involved in medical education during the pandemic, we have really experienced something different. And I think that that will carry that forward, especially with further reflection. But yeah, that's a good question. If maybe it also shows there's more that can be done in a non-pandemic situation to encourage students to reflect on these ethical and moral obligations. And that's why we were thinking about the professional competencies curriculum, which part of that curriculum involves ethical and moral reasoning. And if there's more we can do there with stuff that makes students feel like they're participating in the profession, like simulation in those ways too. Did you have something to add, Chris?
Yeah, I was just going to add in that through our research, we also found a lot of benefit in like narrative reflection as well as service learning in terms of creating that social accountability and social responsibility. So we hope that when the pandemic continues on and progresses to having less restrictions, that we'll be able to implement more of those in our curriculum as well.
There's a question for you guys in the chat. Curious about whether you have a sense of how the pandemic has impacted different students differently, either in your experience or in the study. I'm thinking about the differences between people with kids and without, but maybe there are other factors unique to students as well.
Yeah, absolutely. That was one of our thoughts as well, which is why in our primary study, we actually started off with open-ended questions to allow for that elaboration. Definitely, we couldn't capture every single unique aspect, but we definitely, tried to focus on what was common across all students in terms of, transition to online learning, potential changes in environments such as moving back to home for such younger students, or moving back full-time with their kids as their kids go to online learning. So there's definitely some differences that could still be teased out, and I'm sure will be part of our discussion once we write a manuscript about this, or when we bring it up to the curriculum. Anything else you'd like to add, Roya?
Yeah, another one that we thought of after the fact was students who may be more immunocompromised themselves, or ones who might feel more at risk of contracting COVID or being harmed by COVID for whatever reason in their own personal health. And so getting that information would definitely, or I would assume would change our results in terms of students' willingness to participate in the care of COVID patients, or their worriedness about contracting an infection. So those would definitely be all factors that would help tease those things out. So yeah, definitely very interesting for future research.
Super. Great work, guys. Thanks so much for sharing this with us today.
Thank you.
We'll go to our next presenter now. We next have Jessica Sani, who will speak to us about something I've never heard before. Q methodology to evaluate online anatomy education learning in a COVID-19 context. Jessica, you have the floor.
Hello, everyone. Today I'm representing the education program in anatomy lab at McMaster University, and I'm actually going to start off with a scenario to explain Q methodology a bit. So let's say I own a lemonade stand. Given the ongoing heat wave, all of you visit my stand to get a cold drink, and afterwards I ask you to complete a survey. I find out that there's one group of people whose main complaint is that the lemonade was way too sweet. They may have other complaints, but this is the one thing that stood out specifically for this group as their highest priority. Maybe another group felt that the price of the lemonade was too high, and that's what made them unique. And then there was a third that thought that overall everything was pretty good. One thing all the groups had in common was that they didn't love the location of the lemonade stand. Sure, there was one single individual who didn't like the temperature of the lemonade, and there was one other individual who found the lemonade was actually not sweet enough. But by using Q methodology to discover the major groups and their strongest opinions, I could make strategic changes that have the largest impact. I could address the complaints of each type of person that visited my lemonade stand. And that's what Q methodology is in a nutshell. Today, I'm going to discuss how we used Q methodology to evaluate an anatomy and physiology course that moved online due to the pandemic. All right, so first off, it's important to understand that anatomy education traditionally relies on in-person learning and experiential skill development. Students use cadaveric specimens, 3D models, skeletons, microscopic slides, and other tools in order to understand anatomy, and especially to gauge visuospatial concepts, or where things are in 3D. However, as we are all aware, the ongoing COVID-19 pandemic has drastically changed the face of education, forcing many anatomy courses to move online, which is in direct contrast to the way anatomy is usually taught. So what we were trying to determine was whether anatomy has successfully made the transition to the digital space, especially in the perception of learners. And more specifically, we wanted to explore which aspects of online course delivery in anatomy most positively or negatively resonated with students so that we could improve the course in the future. So as alluded to in my lemonade example, Q methodology is a way to systematically study subjective human opinion. We can use Q methodology in order to identify distinct groups with shared perceptions within a larger group. In the context of education, using Q methodology for course evaluations actually allows instructors to better understand and respond to the needs of their students. So if you look to figure 1 on the left side, you'll see the 3 phases of Q methodology studies. The first phase is survey instrument development. And in this phase, a list of representative statements regarding a subjective topic, such as anatomy education, are selected. These statements are self-referential and opinionated. So for example, one statement we used was, "I prefer online learning compared to the in-person format." The next step to a Q methodology study is data collection. So students are invited to rank all of the statements based on their level of agreement. The table used to rank the statements is displayed in figure 2 in the bottom left corner. And as you can see, the table has a quasi-normal distribution, which forces students to prioritize certain statements over others. The last step to the study is data analysis and interpretation. So researchers determine the correlation between all of the completed tables in order to group people together who have very similar opinions. In our study, data was collected from undergraduate students enrolled in an online introductory anatomy and physiology course at McMaster University. Students completed a Q methodology course evaluation in the fall and the winter semester. And in figure 3, you can see that a total of 166 students were included in the analysis. Results revealing 3 subgroups within the larger cohort, groups 1, 2, and 3. So moving on to results, Q methodology results are typically understood using 2 different types of statements, which are distinguishing and consensus statements. Distinguishing statements are statements that are ranked very differently across groups. In other words, opinions that make a group unique. The lemonade was too sweet, the price was too high. Those opinions make each lemonade group unique. Consensus statements are statements that are ranked similarly across all 3 groups, or feelings that all groups have in common. So if you recall, all of the people who visited the lemonade stand thought the location wasn't ideal. So let's look to table 1, which represents the distinguishing statements or unique viewpoints of the anatomy students. So group 1, the largest group with 66 students, felt that they were comfortable with the technology skills required for studying anatomy online. They were also okay with how lectures and evaluations were run, and they didn't have any strong complaints. Overall, the group could be described as content or even ambivalent. Group 2 was composed of 50 students who were unhappy with several elements of course delivery, including evaluations, specific lab assignments, and the amount of lecture content. In relation to online learning, Group 2 also felt as if they were teaching themselves. Digging deeper, it seems that the students felt they often had to consult external resources and there wasn't enough interaction with professors. And finally, Group 3 was composed of 29 students who were happy, especially with tutorial. They enjoyed synchronous tutorial activities and guidance received from teaching assistants. Certain perceptions were also shared among all 3 groups, evidenced by the consensus statements. Students expressed that they preferred physical rather than virtual specimens. They also strongly agreed that they would appreciate faculty-made practice questions to guide expectations when they are tested on specimens, rather than having to resort to overwhelming online resources. Interestingly, all 3 groups of students did not find synchronous sessions to be a toxic environment, which is in contrast to previous course evaluations of in-person anatomy, where students sometimes felt that others made learning in the lab very difficult. So we've covered what makes each group unique and what all groups share in common. Perhaps a more interesting finding, however, is the fact that there was a major attitude shift among students from the fall to the winter semester. More specifically, students were more unhappy in the fall and fell more so into Group 2, while in the winter, more students were content and shifted into Group 1. So now what? We know how students feel, but how do we move forward from here? It's not enough to invite everyone to the lemonade stand and hear about their imperfect experience. We want to devise solutions that will ensure that our next lemonade stand will be better. So what did we learn from our anatomy students that could be applied to future course iterations? Well, one interesting thing we learned was that there's a shift from unhappiness to ambivalence from the fall to winter. This could suggest that problems posed by online learning are addressed with time. And knowing this, one approach is providing more support to students through the initial adjustment period. For example, instructors could offer more office hours, especially in the first few weeks, so that students who are really struggling can get in touch and adjust more quickly. But it's also important to note that time didn't fix everything. Students did have some persistent concerns surrounding online learning, primarily regarding the use of virtual specimens. They felt the loss of not going to the lab in person and seeing specimens up close. And if the use of virtual specimens is to continue, students need a lot more guidance and a consolidated number of specimens to learn and practice from. Also, knowing how much students actually value physical specimens, perhaps opportunities can be provided for students to visit the lab in a restricted capacity. Overall, we're still in the process of tweaking our lemonade stand and developing solutions based on the results of this study. As mentioned, there's evidence to suggest that student attitudes actually adapt as they become more exposed to online learning, or in other words, the lemonade tastes better the more people drink it. So it will be interesting to see how results differ in the upcoming school year. And given the ongoing uncertainty of the pandemic, we hope to continue exploring student perceptions of online and blended anatomy, thus taking life's lemons and turning them into lemonade stands. On a final note, I'd like to send a big thank you to everyone who supported our project, including McMaster Education Research, Innovation and Theory, or MERIT, and the Faculty of Health Sciences Education Scholarship Fund. We deeply appreciate the support. Thank you.
Thank you, Jessica. Love the lemons, lemonade theme throughout. I've never heard of Q methodology before, but now I feel like I'll sound very smart when I totally steal your lemonade example when I talk to other people. And lots of other people in the group feel the same way. I'll start off with the question, why Q methodology in this context? Why not just survey people's responses to a bunch of questions? What were the advantages of this methodology in your study?
That's a really great question. So usually what people use are Likert scales. Likert scales are open-ended responses. And so with Likert scales, there's a tendency to assume that the entire group is a homogeneous population. So what does a mean to a question really tell you? It doesn't really capture like a bimodal or a trimodal distribution. It just assumes that all of the groups of students have the same personality and have the same concerns. And so Q methodology is better able to kind of tease out the differences in the different personalities of students, allowing us to kind of strategically approach each group and address their concerns. As well, there's sometimes issues with, for example, if there's a Likert scale of 1 to 7, what really is the difference between the numbers? It can be difficult with an ordinal scale for students to actually like tease out what the difference is. And oftentimes they just resort to a more neutral response if they're confused about that. And then in terms of open-ended responses as well, it's difficult for researchers to kind of like sort out what the themes are as well by sifting through every single response. As you can see here, we had like more than 100 responses. So it'd be kind of difficult to do that without some sort of statistical methodology backing us up.
Thank you.
Answer your question?
Yes, for sure. Thank you. That was very, very thoughtful answer. If other people have a question, you can type them in the chat, or you can use the raise hand function, and I can call upon you to ask your question in person. Lots of kudos and shout outs for you, Jess, in the chat. Maybe one last question before we move on. How would you, given the results of your study, what would be maybe the top way, if you can pick one, that you would adapt anatomy education in the future if, God forbid, we have another pandemic and we have to transition to online learning?
That's a really great question. I think that given how persistent the concerns were surrounding virtual specimens, that would probably be the biggest area that would have to be adapted in the upcoming school year. So students have a hard time like understanding virtual specimens, and they feel the loss of not being able to see specimens in person. So definitely a lot more guidance is required there in order to orient students.
Perfect. Jess, there's a question from Jennifer Nash in the chat maybe you can address. And we'll move on to our next speaker. Thanks so much, Jessica.
Great, thank you.
So our final presentation in this session this morning is by Avinash Pandey, and he will speak to us about the virtual delivery of simulation education to undergraduate medical students during the COVID-19 pandemic. Last but not least, Avinash, the floor is yours.
Thank you so much for the introduction. My name is Avinash. I'm a third-year medical student at McMaster, and I'm excited to talk to you about this simulation education project that I, along with some of my colleagues, led over the last year. As I'm sure you're all aware, in-person clinical skills education has been significantly affected during the COVID-19 pandemic. We heard in a previous presentation about how this was actually canceled for a number of months. But in addition, pre-clerkship medical students have had limited opportunities to access the clinical environment due to cancellations of pre-clerkship rotations and pre-clerkship observerships. In addition, there's been a shift in the way that that clinicians have practiced during the COVID-19 pandemic, with an increase in the number of virtual visits and integrated virtual care. We think that this is most likely a shift that will persist as the COVID-19 pandemic comes to a close. And it's an important skill that we think medical students need to develop to be able to assess the risk and triage the care of patients seen via virtual visit or over the phone. These interests led myself and other medical students to develop an innovative simulation-based virtual clinical skills event called MaxSim. We developed a virtual simulation platform called the Med Simulator, which you can see pictures of under our innovation section. The Med Simulator is a platform that we used to deliver virtual simulation education. It allows participants to be able to actually see live and responsive vital sign data to order and receive results for tests such as lab work and imaging, and to actually order treatments, and then which can then affect the vital sign data and affect the investigations that the participants can order. In addition, the Med Simulator platform also incorporates a live simulated patient, which the participants can talk to over Zoom. We organized a one-day clinical skills event using the Med Simulator platform called MaxSim. It involved 42 pre-clerkship medical students who participated in pairs. They obtained a history, a virtual physical exam, and triaged the care of one simulated patient, and then developed an assessment and ordered investigations before deciding on a treatment plan. Participants were assessed by a physician adjudicator, either a resident physician or a faculty member, and then received feedback at the end of the session. We collected pre and post survey data and interviewed 12 of the participants, and survey data was analyzed using Wilcox and sign rank tests. Moving on to the results of our project, 24 participants of the 42 completed our pre-post surveys, and we were able to collect 12 interviews. The survey data was analyzed, and then we also performed themes analysis in the interviews. From the survey data, we found that 92% of participants found that MaxSim was a valuable learning experience, and 96% felt that it would be important to integrate virtual simulation into the formal curriculum. From our interview data, we found a number of themes, 3 of which were that high fidelity virtual simulation is valuable, second of which was that post-event physician feedback improved the learning of participants, and third of which was that students desire more simulation education in the medical school curriculum. So in conclusion, we found that the MaxSim virtual simulation event was a big success. We know that medical students have had limited access to clinical skills education during COVID-19, and we feel that even as this pandemic comes to a close, virtual simulation education will be an important part of medical education in the future, especially as there is a shift towards more virtual care in the coming years. Thank you very much, and I'm happy to answer any questions.
Thank you, Avinash. This is very cool. It's like a medical make your own adventure or escape room type of platform. I have a question. Is this a platform that you guys designed, or is this one that's already been created and you leveraged for this purpose?
That's a great question. We designed this platform ourselves. So the Med Simulator is a virtual platform that we used for this project, but also have since then used in a number of other medical education initiatives and outside of medical education as well. So one example of that was when there was a discussion of whether ICU care was going to need to be triaged. The Hamilton Health Sciences and St. Joe's teams actually used our platform to be able to simulate the triage process for ICU care a few months ago during the COVID-19 pandemic.
Very, very cool. And did you look at facilitator experiences and how those might have compared to in-person sim?
That's a great question. We did not collect information about the facilitator experiences, but it's definitely something that we would be interested in doing in the future. It is, I think, a very different experience to facilitate an in-person simulation than it would be to do this over a virtual platform, and it's certainly something that we should look into.
Very cool. Portia has a question. Portia, you can unmute yourself and ask your question.
Awesome, thank you. Great presentation, very interesting simulation. I was just wondering what your pre-post surveys were asking or testing. So from that, I understand maybe you were trying to see if there is a difference between maybe their knowledge or confidence before and after, but then looking at your survey data, it says Maxim was a valuable learning experience. So I was wondering if that was like a question you asked specifically on the post survey, or if you kind of gleaned that from the pre and post surveys that they completed.
That's a great question. So we did ask surveys to collect information about whether or not participants felt that they had learned things through the experience. There was no sort of actual skill testing pre and post. So we didn't actually test the participants' knowledge before and after, and that would be something we're interested in doing in the future. But we did ask questions about whether or not they felt that Maxim was an effective learning experience, and about the interest of integrating this into the formal curriculum. That was some of the survey.
Okay, awesome, thank you.
Perfect. Any last questions for Avinash before we conclude this super exciting session today? Just going to look through the chat quickly. All right, well, it's 10:56. We've gone a little bit over, but really hard to stay on time when we've had 5 really, really interesting and diverse presentations. I want to thank all the presenters for their hard work today in presenting and on their really, really slick slides, and everybody for participating in the chat today. Lots of great discussion. The next presentations with the curricula theme will begin in 5 minutes. Thanks so much again. Have a great rest of the conference.